SIADH, cerebral salt wasting. By Tracy Merrill MD. February 24, 2003. SIADH equals syndrome of inappropriate ADH secretion. Definition: levels of ADH are inappropriately elevated compared to body's low osmolality, and ADH levels are not suppressed by further decreases in blood osmolality. SIADH causes irritation of sinus, meningitis, encephalitis, brain tumors, brain hemorrhage, hypoxic insult, trauma, brain abscess, Guillain-Barré, hydrocephalus, pulmonary disorders, pneumonia, asthma, positive end expiratory pressure ventilation, SIF, TB, pneumothorax. SIADH causes continued drugs, vincristine, vinblastine, opiates, carbamazepine, cyclophosphamide. Unregulated tumor production of ADH-like peptides, oat cell lung carcinoma for example, Ewing's sarcoma, carcinoma of duodenum, pancreas, thymus. SIADH, function of ADH equals antidiuretic hormone equals vasopressin. ADH is made in the supraoptic nuclei in the hypothalamus, stored in the posterior pituitary. Normally released into the bloodstream when osmoreceptors detect high plasma osmolality. At the kidney, attaches to receptors in the collecting ducts, opens up water channels. Water is passively reabsorbed along the kidney's medullary concentration gradient. SIADH, signs and symptoms: decreased/low urine output. Signs of hyponatremia, lethargy, apathy, disorientation, muscle cramps, anorexia, agitation. Signs of water toxicity, nausea, vomiting, personality changes, confused, combative. If Na less than 110 MEq/L, seizures, bulbar palsies, hypothermia, stupor, coma. SIADH, lab values. Serum Na less than 135, Na is diluted by excessive free water reabsorption. Serum osmolality low, normal is 270. Urine Na is inappropriately high, greater than 20 millimoles/L, actually losing Na in urine instead of retaining it. Urine osmolality is inappropriately high, can range PT300, 1400 musm/L. CVP is high from free water retention. SIADH, treatment fluid restriction, 3/4 maintenance. If symptomatic, may actually need to replace NaCl, can use hypotonic saline for example, 300 cc/m2 of 1.5% NS. Tactics such as Lasix. Treat underlying disorder, for example usually resolves after removal of lung carcinomas. SIADH, treatment can't. Dimeclochlorotetracycline, blocks ADH receptors in the renal collecting ducts. In severe cases, hemodialysis. Warning: if increase Na too fast, at risk for pontine myelinolysis. Max correction of 15 MEq in 24 hours. DI equals diabetes insipidus. Definition: inability to effectively conserve urinary water. Central: ADH not made or not released in the hypothalamic pituitary axis. Nephrogenic: ADH is released but not detected by the receptors in the kidney collecting ducts, often a sex-linked recessive condition, also due to renal pathology, electrolyte disorders, drugs. Central DI, causes head trauma, brain neoplasms, congenital SNES defects. SNES infections. SNES hypoxia. ADH secretion also decreased by certain drugs, Eto, Demerol, MSO4, Dilantin, barbiturates, glucocorticoids. DI. Make sure distinguish DI from conditions in which the presence of non-absorbable, osmotically active solutes in the renal tubules prevent water reabsorption. Example: glucose loss in the urine of diabetics will decrease the tubule medullary concentration gradient, and even though ADH is there, water won't get passively reabsorbed. Central DI, signs/symptoms. Polyuria. Dehydration may not be readily apparent. BC of hyperosmolarity, fluid shifts from cells to intravascular spaces and maintains blood pressure, CVP. Weight loss is a better measure of fluid status. Central DI, lab values hyponatremia, Na greater than 150 to 160. High serum osmolality, normal 270. Urine Na less than 20 mmol/L. Low urine osmolality, very dilute urine. Central DI, treatment. Increase PO4 H20 consumption, use hypotonic saline. Volume replacement cc for cc. Vasopressin/ADH administration, bolus or drip 1.5 to 2.5 μ/kg per hour. Of course, treat underlying cause. Cerebral salt wasting causes, SNES damage, closed head injury. SNES surgery. SNES tumors. SNES infections, meningitis. Cerebral salt wasting signs/symptoms, polyuria, weight loss. Dehydration/hypovolemia. Hypotension. Low CVP. Cerebral salt wasting lab values. Hyponatremia due to excessive renal Na loss. High urine Na, greater than 20 mmol/L. Increased plasma ANP, a trialnitriuretic peptide, BC of low volume status. Inappropriately normal or low aldosterone and ADH levels despite high ANP. Cerebral salt wasting treatment. Volume for volume replacement of urine Na losses. When DC'd from hospital, most will still need oral Na supplementation for a period of time.